And Peter, whom I and you could get figures that, and this is one of his papers talking about 1,500 international unit HCG administered at oocyte retrieval rescues the luteal phase when gonadotrophin releasing hormone agonist is used for ovulation triggering. Unfortunately, when you read the paper and you read the conclusion, you can get fooled with the subtle details. I can point to you here that the delivery rate per patient when GnRH agonist trigger is used is only 24%. When HCG is used, it is 31%. And when you do that very much famous p-value, there is no significant difference. But I think that is a little bit of oversimplification because A, the number used in this study is not enough to detect a difference when it exists. So the beta error is highly likely. Plus, we are all clinicians, and who would sacrifice 7% for the sake of this? So we have to accept that there is a trade-off, and for safety you might have to accept it, but don't tell me that the pregnancy or the delivery rate is similar. And another point, although GnRH agonist plus 1,500 unit of HCG rescue protocol will significantly decrease ovarian hyperstimulation, the risk of severe OHS is still there. So if you didn't want to take a chance, don't use a 1,500 HCG supplement. Another one before I leave GnRH agonist. Any one of the audience has been using GnRH agonist trigger? Yeah? Yeah? Okay. Now, a word of caution. You may have experience already. Sometimes you use GnRH agonist trigger, and when you go to collect the eggs, you find no eggs. And it does happen. And it's important to recognize who are the patient could be at this risk. Sadly, every clinician who is practicing will have been caught out by one or two of these cases. One, you can get cases where they have hypogonadotrophic hypogonadism, but in atypical way, where FSH and LH 3, 2, 4, but we all read in textbook hypogonadotrophic hypogonadism when FSH and LH is under 0.5. Okay, so that's important. Patients also who have been having oral contraceptive pill for a long time. I don't think that will be a problem here because our patient will not be fond of the pill if they are trying for a baby. But in Western countries where the patient will be putting on hold attempting for a baby, using the oral contraceptive for a long time and then come to have IVF, if you're not careful, because it suppresses the pituitary and hypothalamic response, and as such, GnRH agonist will not do the job properly. But a short period of the pill will not have that effect. It's just to avoid making the same mistake as we did when we first started using it. Costing is something that has been in practice and still is, because high levels of estradiol at the time of HCG are predictive of OHS risk. And if we withheld gonadotrophin and delaying HCG trigger until the E2 level declined to a safer level, which is probably you can get away with up to 4,000 picogram per mil. If you use picomole per mil, there is a conversion factor of 3.671, so it will be around 14,000. It reduces the incidence of OHSS if you stop ovarian stimulation before you give HCG for a few days. How many days is controversial. Some people will say the optimal length of costing without affecting pregnancy outcome is up to 3 days. Markaz al-Masri published a paper recently about this, and they are of the opinion that up to 4 days is safe. Beyond this is not particularly great idea, and I would agree with that. The Lister and Sam Abdallah and one of his clinical fellows, James Nokopoulos, published a paper suggesting that you could get pregnancies even if you cost for 8 days, which nobody would disagree with, but the chance of pregnancy overall will be much less, and the number of eggs will be much less. There are some meta-analyses indicating that protective effect, but sadly, there are not many studies in those meta-analyses. Metformin I mentioned earlier, and it is not controversial that giving metformin to patients with PCOS before ovarian stimulation will reduce the risk of OHS. And there are ample studies to demonstrate that. Dopamine agonists and OHSS, because of VEGF being the main mediator, dopamine agonists will work on the VEGF receptors, and something like cabergoline, which is selective, can abolish that effect and hopefully reduce the vascular permeability and reduce the consequences of that predisposition. And there is meta-analysis showing the protective effect of using dopamine agonist or cabergoline. We use it on the day of HCG, and we give 0.5 milligram or 500 microgram daily from day of HCG for 7 days, and it helps. It does not reduce severe hyperstimulation. It will not reduce the latent one that results from pregnancy or the late one, but it will reduce moderate and mild hyperstimulation. And these are the statistics confirming what I've just said. Some albumin and hydroxyethyl starch being used, the results are really not particularly convincing, and I don't think they are in fashion anymore, particularly with the availability of GnRH agonist trigger and coasting. In vitro maturation, immature oocytes are retrieved from minimally stimulated or unstimulated ovaries. You can get large number of immature eggs. I once saw it being done in Brussels, and the guy in no time got about 35 immature eggs, and they put them and they can get 50% maturity, and the patient will not have had any ovarian stimulation. For whatever reason, it is only suitable for patients with PCOS. If they have limited number of follicles or poor responders, forget it. It doesn't help them. Also, the main advantage is to eliminate ovarian hyperstimulation. So now, if you use GnRH agonists, you could reach the same effect, although there is no complete elimination by whatever measure you use. And the technical difficulty of retrieving immature oocytes, the environment the immature eggs will be subjected to at this early stage, and potential imprinting errors make people reluctant to use it at a large scale. Cryopreservation of all embryos is becoming popular, and you need really to have this as an integral part of your program. You need to have very good cryopreservation, and you have statistics to show good survival and intact survival and re-expansion of your blastocyst after survival. And you need also to have good clinical protocol to maximize the outcome from this exercise. If you have those, it is a very good alternative strategy. This is a meta-analysis when people were very enthusiastic on freeze-all first. And unfortunately, the literature is full of noise more than signal sometimes. And this meta-analysis highlights this. The first paper here, you can see Aflatonian 2010 is from Iran. And later, it was shown to be not particularly accurate or honest, whatever you like, and it was retracted from the literature. The other two papers are published from Bruce Shapiro from the state. They are both from the same center with probably doubtful credibility. So it got people to just start off answering this question comprehensively. Some people combine freeze-all with agonist trigger. That is George Grisinger in Lübeck in Germany, and could show that ovarian hyperstimulation was zero with respectable ongoing pregnancy rate per patient and per embryo transfer. There is current research into this area. One of the large, major randomized control trial comparing freeze-all versus fresh replacement is a trial that we are taking part in, and it's funded by the National Institute of Health Research for the matter of £1.6 million. It is likely to report in 2020, I'm afraid, so we'll have to wait. However, there was a recent publication in New England Journal of Medicine just last month, which showing that fresh versus frozen embryos in infertility in the polycystic ovarian syndrome patient. It has demonstrated that if you freeze all for this group of patients, you get 49% live birth rate, and if you replace fresh, you get 42%. I must say, it is interesting, and New England Journal of Medicine is a very prestigious and very rigorous journal and has an impact factor probably of 55 when human reproduction is 4.6 or 4.7. But still, this paper was, or the research work was done in China with grant from the Chinese Institute of Health, and I'm not sure how much research governance was put into this, although I am inclined to believe that New England Journal of Medicine will have checked all of that. And Rick Legro, who is from the state, is a credible author, and he published in New England Journal of Medicine regularly. So I would like to see confirmation of these findings, because I just find it hard to explain the 7% increase in the live births after embryo freezing. In vitro maturation, the results are not very impressive, because if you talk about IVF, the conventional way, you get 44% pregnancy. If you talk about IVM, you get almost 1/3 of this. So for safety, you are far, far compromising effectiveness, and that is something to consider. I can't finish the prevention without mentioning just concept related to treatment. The best approach to treatment is to do a prompt assessment. Sometimes if we felt a patient is at risk, we ask them to come electively. They will come for day 5 transfer, and we ask them to come 2 days later to make sure they are okay. And to make sure they're okay, we do just their full blood count. If the patient is not hemoconcentrated and this basic level is there, reassuring, we can be happy. But the minute the patient starts to show hemoconcentration, we will try to admit them for intravenous fluid and make sure they don't suffer the effect of hyperstimulation. Hydration is essential. As soon as the patient is admitted to the ward, she will have at least 3 liters of fluid per day, and a very strict fluid balance chart, because those patients at risk of developing ARDS, and they must be given Clexane or dalteparin as prophylactic, because they are at risk of clotting, because high estrogen and all of the situation that they have gives them high thrombotic risk. And we do paracentesis or drainage of ascites under 2 conditions. One, if the patient has become so distended that she can't lie flat and she's feeling uncomfortable, then the minute you drain this fluid, the patient will open her eyes and she will feel a lot better. Or if the patient has started showing oliguria, she's not producing more than 10 or 15 ml per hour of urine. There is no prizes for giving the patient acute renal failure, whilst paracentesis will relieve the pressure on the renal veins and give her good diuresis almost instantaneously. And we will not use in these patients under any circumstance HCG. Progesterone support will be good, and most of the hyperstimulation cases, unfortunately, will be pregnant, or fortunately, will leave the hospital with a baby on board. At Guy's and St. Thomas's, probably we'll have one of those, despite our strategies, every maybe 2 or 3 months, which is a huge advance than what we used to have maybe 2 a month in previous days. So in summary, Mr. Chairman, ladies and gentlemen, recognition of at-risk women for ovarian hyperstimulation is crucial. Use of ovarian reserve tests, such as AFC or AMH, if you like it, before stimulation will guide you to identify patient at risk. Individualization of IVF treatment with using GnRH antagonist protocol, reducing gonadotropin dose, using GnRH agonist trigger when it is necessary, intensifying the luteal support for patients who have agonist trigger, routine cycle segmentation, perhaps freeze all and replace later. I never use the word routine in medicine. Individualization is key, because using things routine can disadvantage some unnecessarily. And it is important always to think of safety before effectiveness, and it is ideal if you can achieve a balance between what is safe and what is effective. And I thank you for your attention.
Thank you very much. Very impressive, and I trust very clear presentation. The floor is open for questions.
You're really enjoying your question, Dr. Secretary. You're really getting into that. Yeah. The question is, using a fixed small dose of gonadotrophins of 150 international units per day is safe strategy to reduce ovarian hyperstimulation syndrome? Yes or no? Please vote now. Have you voted, Ahmed? Have you? Yeah. Yes. Yes, I'm sure those who said yes, it's probably my failure to deliver a clear message. 150 is not a safe strategy, because some patients will develop severe ovarian hyperstimulation despite 2.5. So we do not rely on a standard or fixed dose for every patient. It has to be individualized. Yep, next one. Increased VEGF level in response to HCG administration is sole mechanism for increased vascular permeability. Yes or no? Vote now, please. These questions are meant to check whether you were awake or you had to doze off. And 51% of the audience decided to complete their sleep because I mentioned the renin-angiotensin system that is in the ovary that could contribute to that increased vascular permeability. Yeah?
Coffee was not enough.
I know. No, perhaps I sent you to sleep. It's also my fault. Sorry. Yeah. Yeah. The next question is, the luteal phase after GnRH agonist trigger is identical to luteal phase after using HCG to trigger ovulation. Yes or no? That will be serious. Yeah. Please vote now. Have you voted? Yeah. There is some result here. Those who stayed up last night until dawn are excused, really, because they are only 8%. Yeah, fine. Thank you very much for your. Yeah. Any question? Oh, there is one there?
2 more.
I thought we agreed on 3. I've been only paid for 3. Sorry. Administration of dopamine agonist cabergoline from day of HCG for 7 days reduces the pregnancy rates. Yeah. I think in this question, you are free to answer whatever you like, because I did not mention anything about this aspect, and I left it for the question. Yes, 3%. That's impressive, because it doesn't. It does not have any impact on pregnancy. And it's important that this message is clear. Any more? Using GnRH agonist trigger eliminates the risk of ovarian hyperstimulation syndrome. Yes or no? Please vote now. Yes, 26%, 74% are more discerning, and they said no, because it does not eliminate it. You still can get ovarian hyperstimulation despite using GnRH agonist trigger, particularly if you give a small dose of HCG. Any more? Okay, so with this question, unless if the audience have additional question, I thank you for your attention. Ruwa, yeah. Thank you.
Talk, but my question, what's the current situation of costing in the UK now? I mean, any ideas how the percentage of those who, I know it's an old-fashioned somehow, but
sure.
You mentioned some still use it.
Yeah.
Thank you.
I think it still makes sense to use it, but to use it sensibly. How? Because if you can avoid using GnRH agonist trigger and maintain safety, it will be better for outcome. So if stopping the dose for 2 days will give you a safe estrogen level that you can use HCG, that to me is the ideal result. But if you cause that you need 8 days until you get that safe estradiol, please don't do it. Use GnRH agonist trigger at high levels of estradiol and it will be safe.
So quite few.
Yeah. Any other? طبعا يعني with flying colors. Thank you. Yeah.
Thank you very much, Dr.
Pleasure. Thank you.
Yaqub.
Thank you very much. And now, next speaker gives me pleasure to introduce Dr. Hussein Zaki, who is a scientifically very active fellow of the college. And he's one of the, sorry to say, few people who rely on science to develop their practice. And I think this is the right way forward. And today he's going to address us on an exponential increase in pregnancy rate from fresh single euploid transfer at late day 5 rather than day 6. Maybe not very convenient for many practitioners, but hopefully it's going to be a good way to increase our results. Dr. Hussein.
Good afternoon, everybody. Thank you for attending my lecture. I want to thank at the beginning the Egyptian Legislative Committee of the Royal College for inviting me to give this lecture, although I find it extremely difficult to speak after legends, Amr Nouri, Dr. Hassan Salam, Ya'ub Khalaf, Dr. Muhammad Yahya. It's really difficult for me to speak after them, but I'll try to speak logic at the end. My talk is about an exponential increase in pregnancy rate from fresh single aneuploidy transfer at late day 5 rather than day 6. We all know that ART is bound to goodness. We are trying to solve the problems of millions of people, and we have solved already their problems and achieving their dreams by achieving pregnancy. However, it carries a bad side as well. We've just listened to Professor Dr. Ya'ub Khalaf saying that people might die out from it. And we meant not to achieve harm. We're trying to solve people's problem. We're not trying to kill them here. And not only by this, but also the bad side of having multiple pregnancy. We also have an ugly side, turning out that the mother and her baby are in intensive care unit. I needless to say to honorable people like you, professional enough to understand that multiple pregnancy has fetal complications. Twin pregnancy, with many thinking that this is our target, which is not, carries 25% chance of being admitted to neonatal units. And we have a disability, major handicap with twins 10 times of singleton. Not only with the fetus, but rather also to the mother. I have a long list, and I'm sure every one of you know that ART carries risks to the mother with antepartum hemorrhage, preeclampsia, and the list doesn't really end. So for an IVF center like mine, we face a pendulum of problems. We need to achieve high success rate. Our money comes from this. But we're putting more embryos, achieving multiple pregnancy. And the aim was, and still will be, achieving a healthy baby. There is a quest to improve embryo implantation. We always thought that the only way forward is to increase embryo implantation. And that has been achieving the best. The best oocyte, improvement in medications, improvement in stimulation protocols, stepping up, stepping down, being stable, trying to individualize treatment, and also with the assessment of the sperm, doing the recent techniques of sperm DNA fragmentation and better selection of sperms with MC, PIC-C, MAX, different strategies to achieve this, and also with the embryo, with better culture conditions and lab improvements. And the way to do that is to end up by selecting the best embryo. And that has been exposed to the test of time. As this morning we were discussing, we really need to go to day 5 with every single case or not, although it's a debate, some would have opposite views with regard, but this is a test of time which has proven positive, as Professor Dr. Hassan Salam has elaborated nicely this morning, that blastocyst is a way to improving implantation, and also with embryo scoring. We've moved into trying to select embryos with other techniques, especially with morphokinetics, as Professor Hassan Salam again elaborated this morning with morphokinetics. Although my personal opinion, I think many would share with me with that slide, that it does not really tell which embryo is the one I want to transfer back. It tells you the probability. As you can see here, low risk group, medium risk group, high risk group. We have greens and reds. So, is it really the way forward? Or we're just being pushed by companies to implement this technology? Now, all of this methodology, unfortunately, of enhancement, unfortunately have failed short of achieving our goal. Single embryo transfer to deliver a healthy baby, but with high success rate. Aneuploidy has been looked as as a major loss, as a major cause of loss of implantation potential, especially with advanced maternal age. And studies after studies have shown that embryo morphology and scoring has a very weak association with this aneuploidy status. Of course, aneuploidy meaning that the embryo contains the abnormal number of chromosomes. And CCS, comprehensive chromosome screening, has started to emerge as the way that we can achieve that right one embryo. This study by my friend Eric Foreman from Reproductive Medicine Associates in New Jersey, United States, have shown that in 100 consecutive cycles, embryo morphology does not show the right embryo, does not select the right embryo. And the choice has been changed into this study. Eric Foreman has gone one step further, trying to compare, okay, let's go back to our goal. Transferring only one embryo being tested versus 2 excellent quality embryos back, but not being tested. And as this figure has shown us, that with this strategy, single embryo transfer, he and the group has achieved 69% rate of success, achieving clinical pregnancy rate, and in their study, meaning that has passed delivery of 22 weeks, versus 81% of putting 2 embryos. So that's one side of the story. IVI in Valencia, Spain, have started to look at embryo endometrial scoring. And they have found that they can do with gene profiling, looking into cell growth, cell differentiation, cell attachment, immunological factors, looking at 238 genes, they could differentiate from the histology, looking into is it a pre or suggestive of pre-receptive, receptive, and post-receptive. I was trying to really select the word. Is it receptive or is it other words? It is reception. So they can identify by the ERA test, which came out later on, which you can only do in frozen embryo transfer cycle, is it a receptive status or is it post-receptive status? And they looked with another technique, which is a nuclear channel system, have shown that again with this system, they can identify through this, looking into the slides with electron microscopy, to identify if this is a pre-receptive or receptive or post-receptive. But they speak about window of implantation as if we're talking about traffic light. Is it red, then turns into green, turns into red? The endometrium is non-receptive, then suddenly in 1 second become receptive, and then turns back again into non-receptive. Or is it a matter of changing attitude? So it is receptive, become less receptive, then become non-receptive. I look at it as if it is a spectrum or duration. It's not really green or red. No. Even during window of implantation, we have, let's call it, more receptive or less receptive. And I really was inspired by Eric Foreman's study that when he transferred back the euploidy embryo, they do the blastocyst biopsy at day 5, and they transfer it back early day 6. While those of the non-tested embryos, they return it back on day 5. And they've achieved 81%. I mean, that has put me into a state, okay, can we look at the window of implantation into stages or spectrum rather than black or red and green? So we've selected one of the technologies of the CCS. I'm not in favor of micro-ACGH because in micro-ACGH there is 11%. That's confirmatory studies have shown there is 11%. This is high. This is a high number actually of false positive. So with micro-ACGH, you might identify as this embryo being abnormal, and you don't return it back, and it's really normal. So you're wasting good quality euploidy embryos. So I wasn't in favor of that technology. And I used qPCR because this is the only technology that allows fresh transfer. We use this machine, and we use blastous biopsy at day 5, a certain stage, when you can differentiate between Anderson mass and trophoectoderm. You don't really need to see them very expanded, but you really need to see them anyway between achieving stage 4, but not fully expanded. You can take a few cells out from the trophoectoderm, anything between 4 and 6, and we study these. Our study objective was to determine if clinical pregnancy rates were different if embryo transfers performed during day 5 versus early day 6. To be honest with you, I was doing the test, then I sent the figures to United States, and I would receive the results back early day 6. And there and then I can transfer my embryo back. When this has been turned into a computer system that analyzes that to me, that has saved me something like 16 hours. So I can do the test in early day 5, start testing, that would take anything between 4 to 6 hours, put it in the computer, it would tell us exactly which is the euploidy embryo, and that's there and then I transfer back only one embryo. So patient who underwent ICSI cycle and have transferable blastocysts, I call them baby grade, because these are the blastocyst staging that I've seen positive pregnancy test. To us in our center it's 3 BB and above, according to Gordon's criteria, and we do CCS4, then we test them, and we transfer only one embryo back. And we compared that. We started that in January 2016, and we compared the results with a similar group before January 16, and we compared the results. Non-significant age of the patient, non-significant number of previous pregnancies, previous miscarriages, previous attempts, number of oocytes, percentage of fertilization, blast duration rate, number of blastocysts, number of normal, it's a long list. And all these turned out to be non-significant. The only one significant thing was that out of 90 cases that we have transferred back at late day 5, 80 of them got pregnant. And pregnant mean clinical pregnancy rate, and in my definition, if you would like to call it this way, it is beyond 12 weeks. We're not talking about taking a baby home rate, because I believe, as Dr. Professor Hassan Salam has said, it's a multifactorial thing. You might be affected by several things in pregnancies. To me, good embryo, euploidy, passing the 12 weeks stage is to me a clinical pregnancy rate. So out of 90 cases, 80 had achieved pregnancy versus only 51 out of 90 that only have done that through early day 6. We were not the first to show that day 5 is better than day 6. Shapiro in 2001 has shown that day 5 is much better, either with clinical pregnancy rate and implantation. But that raises up question. Why do fresh day 5 blastocysts implant more readily than fresh day 6? And will they do the same if both were transferred in a frozen embryo cycle? And if day 5 or day 6 blastocysts have similar implantation rate in the absence of COS? And do we have other causes? Shapiro back in 2008 have looked, Bruce Shapiro from Nevada, United States, have looked into this, have done a retrospective study, and they've looked into fresh autologous cycles versus frozen cycles versus donation system. And they have shown that with fresh day 5 is better than fresh day 6. However, if of these cases has been exposed to frozen cycle, both will do the same. And again, as Dr. Yacoub has said just a few seconds before, frozen cycles are better than fresh cycles, which is, to me, again, is peculiar. And they've concluded that the difference in implantation potential between day 5 and day 6 is consistent with advanced endometrial development. Don't forget that exposing the endometrium to high level of estrogen, this is what they call superphysiological state, alters what we see now, which that endometrial implantation window goes exactly the same with the embryo implantation window. But then when you stimulate, the story change. Endometrial implantation window start earlier rather than embryo implantation potential. And that's why they say that the frozen cycle is better in these cases. I question this, as I'm going to say later, but I believe that we still have millions of kids have been born from first cycle. How can I ignore this? So we still have to think in first cycles. But why? You've achieved much higher success rates with, is it only an embryo or something you've done? To me, hatching of the embryo is a must to implant. So maybe because we've taken embryo biopsy, we've done laser, of course, so we can getting the cells out. We've done laser assisting hatching, because there is nothing called no hatching before taking the biopsy cells out. So maybe it's the hatching, maybe. Or maybe, and this is one of the things that I've noticed myself, because I am the person who transferred all these embryos back, that late day 5, I find some of the embryos start hatching. And we all know that the blastocyst goes into phases of contraction and re-expansion, expansion and contraction, expansion and contraction. So maybe leave them this 16 hours in the media is not that physiological, and put them back into the uterus, they start the dialogue between endometrium and embryos. So at the end, I would like to say that this study has to be definitely confirmed in the larger study, which we're doing at the moment. And maybe we should think about abandoning day 6 transfer. And I have to say that doing this study and looking into the day 6 that we were doing before, we would do them quite early, anything between 6 and 7 o'clock at the morning, which is actually hassle to the gynecologist, hassle to the lab, hassle to the staff, and hassle to everybody. 6 transfer should be abandoned. And maybe we have to address again the idea or the fashion that started in US heavily, abandoning fresh embryo transfer versus frozen embryo transfer, and saying that even that's good for the baby's health with better baby's weight. I think we have to question that. Maybe you would transfer them back embryos not in the optimum time of implantation. Yes, they are within the window of implantation, but maybe not the optimum time of transfer. I want to thank you all for listening to what I've said. I know it was very much technical, but I really enjoyed having CCS, and I really enjoyed getting this very high success rate. Thank you very much.
Thank you very much.
Let's start some questions here.
Any questions, or shall we move to any questions on the floor?
Need any question? Maybe I think this is different.
Okay, shall we start taking questions from the floor then, till the questions? Okay, Dr. Ruwais.
Thank you, sir, for this initiative. But I have, a cautionary thing, which is DNA testing. I use it. I'm enthusiastic, but the thing is to be scientific is still a debatable thing. And I remember there was in human reproduction of Professor Yaqub corrects me, this was in July this year. It was about repeated miscarriages and DNA testing, and the conclusion was it has no role.
Sure.
So I'm afraid that in a couple of years, maybe at the end of this year, maybe a year from now, the same thing will come into increasing pregnancy rate with DNA testing. So we should be a bit slow and not very enthusiastic before the time comes and these findings are validated. I'm using this technique, but I'm not going to be sort of, very enthusiastic until we know for sure that this is true. Thank you.
Thank you for your question. Number one, I totally agree with you that rushing into CCS just because you're going to solve a certain problem might not be the answer. As we all know, repeated miscarriage by all the means does not mean it was because of an abnormal number of chromosomes, and maybe it with other causes. So definitely if you test this technology versus controversial cause, definitely you would not find. And definitely that study was right in saying, and I've tried it myself, and I found it also that aneuploidy testing by CCS is not the answer for repeated miscarriage cases. But what I'm saying is, this technology has passed through different stages. We've started with saying with day 3, and then we said it's not, or randomized controlled trials find it's not really helpful. But later on, that has evolved and emerged that day 3 biopsy is not good for the embryo. Now, these technologies has passed through at least 10 years of testing, going from ACGH to micro ACGH, then finding that there is a problem with it, then turning into SNP technique, which is much more stable. Next gen sequence, definitely, maybe the way forward. qPCR still. So this has been exposed to validation studies. I know that many would say that the validation studies are not coming from different parts of the world. Like they are mainly confined with the Williams, Schoolcraft, Denver, Colorado, Richard Scott from New Jersey, IVI, but there is no really consensus about it. I don't want you to rush to do CCS for everybody. And if I show you the figures in these patients, definitely the number of embryos that you've achieved reaches a good 10 blastocysts that you test them for. And I must say that I come to the conclusion, okay, which embryo should I put back? I'm fed up from putting 3 embryos, then say, okay, we have multiple pregnancy, then we start miscarriage process. I'm fed up even with twins going into, after 23 years waiting for such a pregnancy, then you lose them just because you put more embryos. Yes, if you are living in Europe or living in London or living in whatever, the state would pay the price. But if you have a lady, and I'm sure that you have faced such ladies, that she has sold her home to achieve success, to do ICSI, and want to achieve success, and definitely will be rushed to put more embryos. You'll say, okay, why don't you put 1 embryo at a time? I must say, until now, in my center, I have not achieved success rate. Although I'm doing vitrification, I haven't succeeded fresh cycles versus frozen cycles. With CCS, which I am admitting, with CCS embryos, so you know that these embryos are euploidy. My success rate in fresh is different from frozen. So I'm not telling you to rush behind this technology. You have to do it cautiously, definitely. Expertise takes very long time. Building up the process is building up time. It is a costly thing. But I must say that I've never met in a certain duration of my life achieving pregnancy rate 80%. Although I'm not saying that my success rate in the center is 80%,
But I'm saying with that group of people achieving 80%, I've never met that. And I must say, thank you for CCS and being able to transfer one embryo. Nobody is paying my patient to do ICSI. We have no state mandate, and we will never have state mandate. So, to me, it is helpful.
Okay, yes, I think I agree with Dr. Sam and Dr. Watt that every invention, time has taught us that every invention when it comes out, it seems to be the solution for everything. It just has got so many benefits, and then a couple of years afterwards, it apparently loses its credibility, and then eventually time comes to tell us where the balance is, where you can get the benefit and where it is useless. So I think we might be starting the era now to say, well, just hold still a bit and wait until the reasonable results come out in the end. Shall we vote for the questions? Okay.
Twin pregnancy should be looked at as an acceptable outcome of ART cycles. Yes or no? Please vote now. Yes. Well, 9 people see here that we have to accept all the complication of preterm delivery, problems to the fetus, problems to the... maybe that's what people ask for. But who said the people know right what to do from what not to do? So definitely no, should not be looked at. Thank you. Second question.
Is it in Egypt or in Europe?
I must say, definitely you're a successful person, you've done many X's, you've seen many multiple pregnancies, you've seen saying hi, thank you very much, but going back and these cases failing achieving the target of delivering the healthy baby, twin pregnancy definitely, even in the United States, there was a study done by Texas University looking what the people would look at. Definitely they look at twin pregnancy. But at the end of the day, they don't know what you know. They don't know what's the percentage of handicap, what's the percentage of having cerebral palsy in preterm pregnancies and with twin pregnancies. So I said should looked at, so that's why not accepted. Question number 2, embryo morphological assessment is a reliable way to exclude aneuploidy embryos. Please vote now. Which means that looking into the embryo and assessing how it looks, does it really tell much about if it's aneuploidy or not? Well, thank you very much. Yes, it does not tell. So the answer is definitely no. Third question. CCS technologies all allow fresh embryo transfer, right or wrong? Please vote now. That's true. No. It's only one technique that allows fresh embryo transfer, which is the qPCR. Having said that, we are looking at NGS for the time being, giving results in anything between 12 and 18 hours. But again, that would not allow fresh embryo transfer. But the technology is going quite fast, so hoping that it would turn to fresh later on. Is there a further question, I guess? In your opinion, to achieve the goal or the way forward, should we put law of enforcement, apply technologies that will achieve the target of better embryo selection, or, well, it's not a problem having multiple pregnancy anyway? Please vote now. That's in your opinion. That's not a right or wrong question. Well, thank you very much. Yes, that's the answer. Apply new technologies. But we shouldn't rush behind them. And I must say, CCS is not for everybody. And definitely it has a limited space with young patients where the percentage of aneuploidy is really less than 40%. But when you go to an elder patient, meaning above 34, 35 years old, I guess that might be the answer. Thank you very much, and I really appreciate your listening.
Thank you very much, Dr. Hussam, and thank you very much. I'd like to thank the speakers, and would like very much to thank my co-chairman, our guest of honor, Mr. Hani Fauzi, and I'd like now to invite the chairpersons for the next session, please. Thank you.
Dr. Said.
How to? Okay, now it's my pleasure to start this session. I hope the audiovisual is ready. Otherwise, you will get us into trouble with the dean.
No worries.
Yeah. Yes, أنا عارف أنا الهادي. Okay, so it's my pleasure now to introduce the Professor Saeed Abdel Hadi. I'm sure all of you know, but he's the Dean of the Faculty of Medicine, Mansoura University. He was trained like me in the United Kingdom, and he's flying the flag for proper gynecological, oncological surgery and care, not just in Mansoura, but I think the whole of Delta, and becoming instrumental in trying to put some sense in the care for cancer patients. Professor Saeed.
Oh, thank you very much, Mr. Chairman, and pleased to be here among friends and colleagues, and pleased also to change the way forward from infertility to cancer and infertility. I would say I'd like to answer these three questions, and first I would say it in Arabic. If a patient comes to you suffering infertility, I would ask you, doctor, I'm going to develop cancer, as I heard from the media that being infertile will predispose me to getting cancer. And the opposite is correct. If you're getting a patient who has had 10 cycles or more of ICSI, and one day she comes to say, oh, doctor, does this exposes me to develop cancer? Or does this exposes my kids, my offspring, to get cancer one day? Because I have heard about that. And the third category of patients who are now we're more seeing day by day are the young people who develop cancer. These unfortunate people who are looking forward to preserve their fertility. Can we do something for them? I think these are the three ones, and I would promise to finish in 15 minutes, so 5 minutes are more than enough for each one. As I was asked to put some question in, can you? Yeah, okay. So the first question is, okay. It's coming? Yeah, all right. is maybe a waking episode just to focus on the presentation. Infertility is associated with an increased prevalence of any of the following cancers. One or more, all or none rule may be correct. So if you want to vote, just see how it goes. Uterine cancer, ovarian cancer, breast, cervical, and vulval carcinoma. What you think is more linked to infertility than other? Okay. Yeah. Can I have the answer, please? Okay, come on. Okay. Ovarian is the most cited here. We will see how it goes. But I would say A, B, and C are correct. So next, please. Next question. Next one here, please. Quiz number 2. You follow? All right.
We can please vote. Nobody's voting.
Fine. Sorry for the delay, but we will finish in a shorter time. I will read the question. Infertility treatment like ovulation induction, in vitro fertilization, and intracytoplasmic sperm injection is associated with a significantly increased prevalence of cancer. And grade your approve to this is either strongly agree, disagree, no evidence of that, or I don't know. Please vote now. Is associated with a significantly increased prevalence of cancer. We're going to see. I will go with this who said no evidence. Thank you. Next one, or the last one.
Can you read the question?
I will read. You ready? Okay. Fertility preservation techniques should be offered to young people with cancer. Strongly agree, disagree, no evidence, or I don't know. All vote now, please. Oh, yes. Thank you very much. Then there is no need to carry on with the presentation. All the answers seems to be correct. Thank you very much. I'm going back to the presentation. All right? Yeah. Before we say cancer, is which type of cancer you mean? Any type of cancer. We stress here about the hormone-dependent endometrial and ovarian carcinoma and the non-hormone-dependent cervical carcinoma, and hormone-dependent endometrial and breast, non-hormone-dependent like ovary and the cervix. And which infertility factor? So we need to be more focused. Do we speak about ovulatory disorders, mostly PCOS? We speak about endometriosis or the unexplained infertility. That article in the Placenta in 2008, Infertility as a Cancer Risk Factor, is a review. They stated that ovarian, endometrial, and breast cancers are associated with, and here we need to stress in this point, between association and causation. We're going to repeat that one. Low parity, infertility, early age at menarche, and late age at the menopause. These are definite epidemiological risk factors to develop breast and endometrial carcinoma. Are they the cause of infertility? Are they the cause of cancer? Or both? In fact, most of these risk factors are associations. Do you remember when we were students at the medical school about corpus cancer syndrome, the risk factor that predispose to endometrial carcinoma? Or 3, obesity, diabetes mellitus, and hypertension. Nobody thought of putting them into a multivariate analysis to see which is dependent and which is an independent risk factor. And simply hypertension is not a cause of cancer. Hypertension is an association. But obesity and diabetes are causation because they are associated with excess estrogen. So you now appreciate there is difference between infertility causing cancer and infertility is associated with cancer. Okay? And that's going to stand all through the presentation. In conclusion, firm answers about the precise effects of infertility are not proved. In this case, we said there is no evidence. But there is some evidence that infertility leads to endometrial carcinoma. Again, it is an association and not a causation, except if infertility is caused by polycystic ovarian syndrome. But looking at the evidence, there is epidemiological evidence, yes, infertility is associated, or is caused by polycystic ovarian syndrome, and polycystic ovarian syndrome causes endometrial carcinoma. That's well known, but look at the evidence. There are 2 cases that say that polycystic ovarian syndrome, if untreated for 16 years in one study and 14 years another study, can lead to endometrial carcinoma. Do you know why we don't have evidence? Because that is not an ethical study. You cannot run a study with the end point of developing cancer. Nobody in the world will allow you to do that. And so there is no evidence doesn't mean, the lack of evidence doesn't mean there is no evidence, but simply nobody will allow to do that. Dr. Sikotori will remember in the 50s, an Australian gynecologist thought that HPV and CIN never progressed to cervical carcinoma. He just waited 14 years, and all women developed cervical cancer. That's no one is now allowed to wait for a CIN to develop cancer, exactly in the same way like endometrial carcinoma and polycystic ovarian. Infertility and ovarian carcinoma, you are all aware of the paper. It's actually a letter to the editor of our great professor Mahmoud Fathallah, that's published in the Lancet in 1972. That was a mere epidemiological study linking uninterrupted ovulation to ovarian cancer. He just looked at the data files in a reproductive center in Edinburgh and found that women who are infertile or with an uninterrupted ovulation are more liable to develop ovarian cancer. That was published in the Lancet. This epidemiological evidence is correct. But at that time, they thought just continuous ovulation causes trauma and leads to ovarian carcinoma. After more than 30 years, we now believe that the epidemiology is correct, and it's always correct, but the science is different. The trauma of ovulation brings some tubes from the fallopian tubes that are atypical to settle in the ovary and later develop ovarian carcinoma. So, can infertility point to ovarian cancer? There is some new evidence that I want to point on this one. Sutcliffe in London, probably known to Dr. Yaqub Khalaf, he published, he's an epidemiologist, by the way. He found 2 interesting observations. Infertile women are 1.3 more likely to develop cancer than non-infertile women. And there is another interesting observation that tubal ligation and perhaps removing the tubes will reduce the risk of developing ovarian cancer by 1/3. So there is something here to speak about epidemiology, and as scientists we have to search for the evidence. What is the evidence? The evidence just comes very recently. That paper just last month, you just published, linking BRCA1, breast cancer antigen 1, to infertility. So people who have mutation of the BRCA1 are more liable to develop breast and ovarian carcinoma and low fertility index with probably low anti-Mullerian hormone. So we know there is a new avenue that people who are more liable to develop breast and ovarian cancer because of the mutation in the breast cancer antigen 1 and 2, they have low fertility index because of reduced anti-Mullerian hormones. Infertility and cervical carcinoma, you will find epidemiologically it is correct, but scientifically, because of the cause. Cervical carcinoma is caused by human papillomavirus, mostly the character of the patients who are getting chlamydia. Chlamydia damages the tube, but the cause is totally different. The virus causes cervical carcinoma, chlamydia causes destruction of the tube. But epidemiologically, it will appear correct. You have to find for the science behind that one. Fertility and breast carcinoma is more heavily studied than any other gynecological cancer. There is hormonal factors in the breast and the infertility, as we said, like early menarche, late menopause, women who have never lactated. These are epidemiologically correct and nobody could doubt, but what is the evidence? Associated factors, that is the key one, and sometimes genetic, as we just said, BRCA1 and 2. Infertility and breast cancer, there is a link that's published earlier this year, and the answer is reassuring. There is no link between infertility and cancer. Infertility does not cause breast cancer. Simply, infertility and breast cancer are caused by hormonal or genetic factors, but they are not dependent on each other. That is, they are dependent on hormones, but not dependent on the causation. And this statistical meaning needs to be very well understood. That's the second point, infertility interventions and the risk of developing cancer. Having repeated IVF cycles exposed me to cancer, doctor, and the answer is no. Quite reassuring, very recent evidence, July 2015, and they done a very controlled study as an independent risk factor to develop cervical, endometrial, ovarian, and breast carcinoma following IVF. The numbers are huge and systematic review and meta-analysis, which would give you a level 1 evidence or a level A recommendation. More than 800,000 women exposed. The meta-analysis found no significant association between ovarian stimulation, IVF cycles, and endometrial, cervical, or breast and ovarian carcinoma. That's very reassuring to tell women. I think 10 years ago, they used to say exposing women to high estrogen and IVF cycles and so will predispose them to any of these. I think that paper would end that claim, and you can now assure your patients that exposing you to IVF, how many cycles you get, does not increase the risk of breast carcinoma, and also does not increase the frequency of monitoring or follow-up or screening for breast carcinoma. And that's important observation. This last part of this is there is a risk for the offspring. That's a very good paper published in Human Reproduction and says no. Having babies as a result of IVF or XE or even ovarian stimulation does not increase the probability of developing cancer in this offspring. So the technique is more or less reassuring. And the New England Journal of Medicine with the highest impact factor, and that's a bridge study, and the conclusion is there is no evidence whatsoever that the babies coming from IVF or XE are more liable to develop breast carcinoma or cancer in general. The last part, because I promised I'm going to finish, fertility preservation is a very vast topic, but I'm just hitting 2-3 slides. It's now called oncofertility specialist. So in the future, me and secretary will become oncofertility specialist and will compete with you for the fertility or the fertility preservation medicine. The new field is growing. Now, many conferences which are held for that topic, and 1 in 10 of the young population who develop cancer. And more interestingly, because they have done innovations in IVF, you can now get certain difficulties with cancer, more liable to get pregnant, and also advancement in cancer treatment, prolonged survival of these patients. So you have good, and have done good, and as a result, the pool of people with cancer who are seeking for fertility preservation is increasing. That will require a consortium. That's called the Onco-Fertility Consortium. I'm aware of 5 or 6 countries who have that one, the last one in Japan, but definitely in New York there is the Onco-Fertility Consortium for the USA, and it's working fine. In many countries, in England there is one, I'm aware of Spain as well, and these are a group of physicians who are working together, including the gynecologists. So secretary, we need to be there, okay? Simply, that's maybe the last slide in the presentation. If you are seeing a cancer patient who is quite young and seeking for fertility, you have to refer to this consortium. This is a group of people working together. Very simply, in male and mature one, you can do just semen cryopreservation, which can survive for ages. If it's before the puberty, you can do, revise the medication either to in the female patients. We do every day now fertility sparing treatment modification. You are not oncologists, you are not interested in going in this field, but in each cancer now we can preserve fertility quite successfully. IVF, embryo and cryopreservation, that's your job, you do it every day, okay? Before cancer treatment, you just, if the woman is married in this country, you take the oocytes from the woman and the sperm from the husband, you do IVF or ICSI, and you cryopreserve. And your results, as I heard this morning, are more even better than the fresh one. Should no problem. Sorry. I mean, you remove the ovaries away from the field if you're doing radiotherapy. We do it quite easy. Laparoscopically, you just take the ovaries below the liver or below the kidneys, the spleen on the left side. Remove them from the field. It's done laparoscopically quite easily, or open if you don't have that facility, but it works. It works quite well. Oocyte cryopreservation, I think you heard about that. It's not as successful as embryo cryopreservation, but it is there. Ovarian tissue cryopreservation, in my point of view, is the most successful in this country for girls who are not married yet. You can take the ovaries, put them in the fridge, and do treatment as you like, return them back either to the same side, or you can put in the abdominal wall or in the abdominal. I think there is a guy from Alexandria who has done mincing of these follicles and then put it under the arm, taking them back. It's quite working. So we can do quite good jobs to help these. So, as I said that one, we are now more inclined to fertility preservation and the little that can work. In each cancer, we remove the little that can work. From the breast to the ovary to the cervix, that's the little that can work. Just remove the cancer-appearing area with safety margin and lymph nodes. Maybe now we do sentinel lymph node, so a patient with early invasive carcinoma, we can do a very minimal surgery, it doesn't take long. Sentinel node negative, you can do, you remember this Fothergill operation, put a stitch around the neck of the cervix, remove the cervix, and remove one or more lymph nodes. There are many modifications that can do, it's working. As I said, we are in this country looking forward to have this Onco-Fertility Consortium for Egypt, and I invite you to think about that. We have the eminent Professor Salam, perhaps you have to think of that one. Onco-fertility in Egypt, we hope so. So, to answer the 3 questions, there is an association, but not a causation, between infertility and the hormone-dependent endometrium and breast carcinoma and the non-hormone-dependent ovarian and cervical carcinoma. It is mere association. If you remove the causes, then infertility will not cause cancer. The second is infertility treatment does not increase the risk of developing any cancer, either in the patient or in her offspring. And you can safely assure your patients with the current evidence, that there is no evidence of increased risk, especially cancer. And the third one, all young patients with cancer should be counseled regarding fertility preservation techniques. I thank you very much and wish you a happy day. Questions ready? Oh, yeah. I have just put 3 questions, so you added 2? Yeah, so you put the question at the end. That's repeated. I think they just missed it. If you can answer now, we already done that. I think we already done that. But does infertility increase the risk of developing cancer in women? I know now there is an association between endometrial, ovarian, and cervical and breast carcinoma, but never a causation. We already done that. And no, I already done it. I think they just pulled it from the text till the end. But we've done the question, and I thank you very much. I can answer any question if you like.
Thank you very much, Professor Said, for this very clear presentation as usual. We'll probably have time for a couple of questions from the floor. Yes.
Thank you, Said.
Thank you, sir.
For how long did this guy prove that treatment of infertility does not produce cancer? Because it also depends on for how long and how many years did he follow the one. Because if we say that there is some kind of association or causation or whatever with infertility, between infertility and cancer, then if he just takes a number, whatever large it is, and studies it for a short period of time, who have been given treatment, I don't think this is really, I wouldn't take that to this value.
Fine. Absolutely correct. We are speaking about how long is the follow-up for these patients. And in the British study that's published in the New England Journal of Medicine, they took 17 years as an average, with some time between 5 years and 35 years. I think if you get after 17 years of follow-up, lack of evidence of an increased prevalence of malignancy, you can say yes. But we will not follow up these guys or these women till the end of life. Definitely we speak about the current evidence, but you are correct. In the short term, we used to say no, but there are some few long-term studies that say also it is safe. Okay.
Thank you very much.
Thank you.
It's a beautiful presentation. I just want to mention something that because I'm an old man, I was quite young. When we started doing IVF in England in 1981, there was no vagina ultrasound.
Right.
So we used to do a collection of abdominal ultrasound. This is something which is good nowadays for young girls who are virgins and who have cancer. So this is the way we do it. And of course, freezing oocytes is now improving with the vitrification.
Yeah.
So this is the way we do it.
Yeah, absolutely.
With training, I think everybody
can collect the embryo. Fine, thank you. You got the point. It's an interesting point for virgins. You don't need to go transvaginally to collect the oocytes. You can go transabdominal. Thank you, sir. It's very intelligent observation that I really did not know. Yeah, I really did not know. Thank you, sir.
Yes. Professor Said, I have a question.
Thank you,
Now, there is quite very common that our patient would be asking this direct question: use of infertility, ovulation-inducing drugs would cause cancer. Now, I don't feel comfortable, even in the view of these evidences, to say no. And I'm trying to say something in the best current of evidence right now: no. So I don't know what's the situation in the UK colleagues if they are asked this question, how they counsel the patients and use the words.
I just leave Professor Khalaf to answer, but I remember my good days in the UK. We used these terms. I think Jacob is going to tell it. There is no evidence, but there is no guarantee.
The thing is, the way you use
You
your word,
remember
that's the thing I would like to hear.
I think we can only work on the best available evidence. And if there is currently no evidence to suggest that what we do is unsafe, that is all what the patient would like to hear.
Oh, yeah.
That's
Okay.
Yes, and what I just also want to say that there are certain conditions that are associated with infertility and maybe cancer, like endometriosis, for example. And in the last WHO classification, histological classification and grading for ovarian tumors, they put endometrioma as the first time to put it amongst the ovarian tumors. So we don't know, but we just say at the current available evidence, دلوقتي ما نعرفش. بس برضو be on the reassuring side. On the reassure, because this lady is going for fertility treatment no matter what you say.
Thank you, sir. As again, coming for nice observation from an oncologist, definitely now we know that endometriomas can increase or increases the risk of developing endometriosis type of cancer and borderline tumors. But for how certain it is, we can debate that in an oncology meeting, but for infertility, we just reassure. But definitely there is a risk, yeah.
But we can also further reassure them that people do IVF not for the fun of it, but to have a baby.
True.
And having a baby is protective against ovarian cancer. So even if there is theoretical risk, will be neutralized.
Thank you.
Yeah.
That's definitely good.
Okay, I think. One more question? Okay.
I would think.
Does the past years of ovarian cancer from induction of ovulation vanished nowadays?
Can you repeat the question, sir?
Induction of ovulation was in the past was a fear for
that was
cancer,
an allegation.
Cancer ovary.
Yeah, that was an allegation. With this evidence, I would say safely, yes. I think more than 10 years we had this debate.
30%.
This study was 178 plus thousand follow-ups after IVF-XZ. It came out last year in July, and there is no evidence whatsoever. The p-value is 0.9, something that is equal to the control. If you get the control is 1, so the population, huge number of population who are exposed are getting very close to the control. So now safely we can, with that evidence, say with certain degree of accuracy, this does not increase the risk of getting cancer. Maybe in the future there may be something we don't know.
Okay, thank you.
Thank you very much.
Our next speaker actually apologized, Professor Shamil Anani, for not being able to come due to some circumstances. So we came into the end of this session. I would like to thank all the attendants. I would like to thank my colleagues and the ARC members, and Professor Am is going to have a word before we close.
Thank you very much, Mr. I would like to thank you very much. I would like to thank actually all the speakers who enriched this meeting, and the chairman and the audience who interacted in this meeting. I would like also to thank Mina Farm for supporting this and for the live streaming. Actually, this meeting is actually was live on satellite, and you will be able to actually go through the internet after that and see the meeting if you would like to see the meeting and the discussion. So I would like to thank you all. I just want to remind you that we have other activities going on. There will be a pelvic floor surgery with colleagues from the UK and from Egypt. This will be on October. There will be actually a laparoscopic suturing course also in November, and a laparoscopic hysterectomy course in November as well. One will be in Asr al-Aini and other one in Ain Shams. There will be a basic practical skills course from the Royal College, and you get the certificate from the Royal College directly. So really there is a lot of activity, and I want to remind you about our big event in March, where there will be around 60 speakers from all over the world, and UK and Egypt. So really put all this in your calendar. I would like to thank you all again for coming, and thank you very much. Okay.